everybody. I'm a little bit late because we're still busy. We had our Corona crisis meeting, so I could not join you earlier. And I want to thank again Imad and Vlad for inviting me. And they asked me to present one of the difficult cases who gave me a lot of gray hair. And then I have several, but I selected that one, which I want to present to you.
Now we know where is your gray hair coming from.
Okay, this was a 41-year-old male, and he was a truck driver, and he was in a roundabout, and he was circulating once, twice, 3 times, 4, 5, 6, and then the police caught him and brought him out and said, "Hey guy, what's wrong with you?" And he was completely disoriented. And then he came to the clinic, and you saw he was really in a bad shape. He had obviously an Addison crisis. He had a decreased visual acuity, a little bit visual field deficit, and especially his wife was complaining of slowly increasing memory problems, mental decline, and fatigue. And then he got an emergency CT scan, and you see this suprasellar and retrosellar calcified lesion with a small or normally shaped cellar. So obviously this could be a craniopharyngioma. And you see he has already a little bit hydrocephalus because both foramen of Monro were blocked. Then he underwent MR imaging, and you see there's a huge tumor extending into the third ventricle, pushing the brainstem backwards, retroclival extension. And if you look to the T2 weighted axial images, you see this perifocal edema as a sign of hypothalamus invasion, explaining his endocrinological problems. Endocrinological shows that he was pan-hypopit with DI, Addison crisis, and ophthalmologic investigation shows a temporal lower quadrant anopsia on the left side and a reduced visual acuity. So obviously we have to do something, but what is the best approach to that lesion? Of course, if you see that, you would say, okay, transcallosal is an option, but the foramina was small, so you have to open the choroid fissure, can be done. This would be one option because you have a straight line down, but you see it's very deep. It's a very deep corridor to go here behind the clivus. What is another option? I think translaminar terminalis is not a good idea. Pterional, like we did all the cranius previously, would be an option, of course, but also difficult to see down. Or we make an endoscopic endonasal one. Then we can drill here the tuberculum, we can drill the stellar floor, and we can take a little bit of the clivus. So bone here is very thin, so it is not difficult to reach the tumor. So then we said, okay, we try endoscopic endonasal, although it's a calcified lesion and you might expect it can be a difficult case. So positioning, patient is supine, of course, and we elevate the table at least 30 degrees to decrease the venous pressure in the cavernous sinus, and we turn the head and tilt the head so that we have a convenient position. We prepare the nose with epinephrine 1/1000, and then of course 4 hands technique for dissection and preparation in the binostril approach. So the surgery was done on June 2011, and this was one of my first cases of craniopharyngiomas. We make a transsellar, transclival, transtuberculum, transplanum approach, and then we raised a head flap to cover the defect. And here's a very well pneumatized sinus. You see clinoidal segment of the carotid, cavernous segment, clival segment, optic nerve, lateral OCR, medial OCR. So we removed all the bone, removed the clivus in the upper part, and then we make a pituitary transposition because we need access. And because he was already pan-hypopit, I think we can do that because anyhow the gland is not working well. And then we have the tumor in the lower part of the approach. Here's the basilar artery coming, And you see the tumor is very fibrous. There were no chance. I tried ultrasonic aspiration, but was not working. And it was really a tedious dissection because the tumor was so sticky to all the structures. It was not easily to dissect, and it took a lot of time. Here we can elevate the tumor on the left side. You see the third nerve below, superior cerebellar artery, and you see this is a small PCOM, very tiny PCOM, and everything was sticky. And we had to dissect. You know, pulling is a bad advice in this approach because you never know what is sticky to the tumor. So we had to dissect in the arachnoid plane, and this took a lot of time. You see mammillary bodies here in the back, and then the tumor was not coming down. There's no chance, and we have this old ENT instrument which goes 2 centimeters up. It was difficult to go in and go out, but then we could dissect, and there was a clear infiltration. Yeah, initially I tried to preserve the stalk, but the stalk was basically completely destroyed by the tumor, so we took it out. But you see, when you make a transposition, you have a swelling. It's a blue dead thing. So I think a pituitary transposition in this way is not a good idea. And you see here this infiltration. Of course, we did not make any attempt to remove it because you end up in the white tissue of the hypothalamus and you have to stop. So there was a covering of tumor around in the dissection hole to avoid additional hypothalamic damage. You see the foramen of Monro are not very wide. And then how to close this defect? We put a little bit of Tachocil on the bone and then our flap. I put no fat because I was afraid the fat is falling down into this subarachnoid space. Histology showed it was an adamantinomous craniopharyngioma. And after surgery, he was very agitated, aggressive, disoriented. So, of course, is what you expect in such a tumor. But finally, after some days, his condition became better and better. And also in the endocrinology, of course, he has DI as expected. He had already before, but then he had a salt wasting syndrome, according to our endocrinologist, which needs to be treated. All the signs that the hypothalamus was involved. And then you see the next day after surgery, we make an MRI, and you see our scalpus reconstruction was floating in the cavity. And here was our flap. So we made a revision, second day, second surgery, and we took a lot of fat, put it in, that it's not falling into cavity, then the flap and then another fat. But you see the flap is not very well perfused. And then he put a lumbar drain for 7 days. And even after 7 days, he is not stopping leaking. So the fourth surgery was a VP shunt to reduce the pressure. And then after 14 days, it looks not too bad. But then again, he had some water coming out of the nose, and we made an inspection with fluorescein with our ENT doctors, but they found no leakage. And then again, 4 days later, there was a sign of CSF flow, and we make an nasal revision with fluorescein, and then we found a small leakage where we put some fat and fibrin glue. And then he had vomiting for some days, and he had an oral hydrocortisone replacement therapy, and because of this vomiting, he had an Addison crisis, and then again he needs hydrocortisone. This was in August, 12th of August. But then after 7 weeks after this surgery, which took, the initial surgery took 12 hours, because everything was so firm and sticky, and we had only used sharp and blunt dissection to remove the tumor. And after 7 weeks, he was doing good, was oriented, visual field improved, and he was sent for discharge to the rehab unit. And then 6 months after surgery, he came back for control, and you see here, this is a small remnant on the hypothalamus. Reconstruction is good, and he was doing fine. Inspection shows a good healing of the flap, only a little bit of crusting here in the middle part. And then he received fractionated stereotactic radiotherapy for the remnant, 54 grays, 30 fractions. And 24 months after the first surgery, he came back with this MRI. You see the tumor is here, more or less stable, but he developed a cystic recurrence in the lateral ventricle on the left side. So the question is what to do with this. Of course, straightforward would be a transcallosal approach to get it out, but we opted for transcortical endoscopic resection with the LOTA system. So with navigation guidance, the endoscope is brought in. You see this was the head of the choroid nucleus, and immediately you see the cyst of the craniopharyngioma. So we open the cyst with a bipolar rod, and you see the typical craniopharyngioma content is escaping. So we enlarge the opening, and then we put a suction tube. It's an endotracheal suction tube from the histologist. We put it in the lesion and aspirated all the content. And then with a bimanual technique, we make a resection of this cystic. Yeah, what is it? Is it a metastasis? I think it's a metastasis, or it's in continuity. Difficult to say. Tumor is resected. You see the choroid plexus on this side. Tumor was sticky to the choroid plexus, so we had to use sharp dissection to detach it from the choroid plexus. And then the tumor is further resected, preserving the veins here. And after detaching of the veins was easy, then we had just to take grasping forceps to remove the tumor, which was sticky to the septum, to make sure we have really a gross total resection of this lesion. Small bleedings were controlled with a bipolar diathermy electrode. And then the tumor is removed, and you see it's just the white septal tissue which is remaining. And you see here, so VP shunt catheter is here. And at the same session, we removed the VP shunt. And histology again was this typical craniopharyngioma. And then 3 months after the 7th surgery, you see the gross total resection. He was doing well. But you see here is a little bit enlargement of this radiated part in the original area of the craniopharyngioma. And 30 months after the first surgery, he has a cystic recurrence. And then we were thinking what to do. After the experience with this leakage, we had not much intention to make another endonasal surgery, but we made just a frontolateral cyst fenestration. So we went in here, the lamina terminalis is opened. This optic nerve on the right side. So we opened the cyst. It was not the typical content of the craniopharyngioma, it was more like CSF. And we took a little bit of the wall for the histology. And then we went in the optocarotid window on the lateral side. Carotid is here, optic is here, and we make a wide fenestration of the cyst. But no attempt was made to remove this calcified part, which is so sticky to the hypothalamus. And then histology showed only regressive remnants of the craniopharyngioma, but no vital tumor cells. So obviously it is not tumor what was growing, but just a pseudocyst formation after radiation. And we opened this, and since then he did not develop any recurrence. So the radiation therapy was working. And the last visit was now after 9 years. He has no gain of weight, surprisingly, no memory problems, according to his wife, visual field deficit resolved, and he's back to work, not as a car driver, but he's working, I think, in a store or so. But he has full hormonal replacement. But finally, I think I'm quite happy with the result. He's doing well, enjoying his life with hormonal substitution. And I was always arguing with myself, should I make a transcallosal approach initially to avoid the CSF leakage problem. Was my flap too small, which is probably the problem. But also the hydrocephalus, with which he presented before. We have another case where we also needed a shunt, and also this patient had a hydrocephalus because of his craniopharyngioma. This might play a role. But finally, I think it's quite acceptable result, especially that he did not gain weight. And yeah, so far, and I would be happy to hear the opinions of the panel. Thank you for your attention. You muted.
Oh, sorry. Thank you so much for the good presentation and for the very interesting case, indeed. I was going to ask you, you started your journey with this patient, 10 years ago. What would you do differently if you had to start now?
Make a better nasoseptal flap. But I would come again enonasally. I would not come transcallosally. I think the preservation of the hypothalamus, I think it's better when you come from below. I don't know. When we changed our craniopharyngiomas to enonasal in the last years, and I think the results is regarding obesity is better when you come from enonasal, at least in our series. Would
you combine two approaches to do that on the first instance, and like that have a smaller opening transnasal and maybe?
No. I think I would do the same. I know when you open the clivus, you have always a higher leak rate than you make it just a transtuberculum approach. That is really the problem. What we also see in chordoma patients. Sometimes it's difficult to get the CSF leakage controlled, but I think for the brain preservation and to see all the structures and to have good dissection under direct visualization, I don't know. I think enonasal is better. I'm really a fan of that.
Yeah, okay. So maybe the rest of the panel?
Yes, I have one question. Yeah. Well, thank you, Henry, for sharing this experience. And of course, it's very easy sitting on my chair and comment retrospectively on such a case. In my practice, when it's heavily calcified lesion, and you demonstrated how difficult is the dissection, and we are talking to somebody who is mastering the endoscopic surgery and managed to some extent to dissect nicely like a microsurgeon from below. But for the sake of young generation, and I think a heavily calcified craniopharyngioma from below is a tough entertainment and tough procedure for them. And I still believe lamina terminalis is one of the approaches. And you might go in 1 or 2 stages. You might go and to decompress as much as you can. Or the transcallosal, you mentioned you need to go because the foramina was tight, not enlarged. You have to go midline, and it's tough sometimes. But lamina terminalis has been a common approach to these cases. And we have done similar size, heavily calcified craniopharyngioma with relatively good results, especially in adult, not in pediatric. Pediatric, they can be tough with the obesity and other things because hypothalamic disturbance. Interestingly, is more worse in pediatric age group than the adult age group. But I feel when I see a heavily calcified midline craniopharyngioma, I am hesitant to go from below. You might go transterminalis, and then you leave the small portion that you could not achieve. You said there is a lower caudal component. If you don't achieve to take it from above, you might still go from below and take that small component rather than to try to dissect the whole calcified component from above. I understand that you get the white hair, not single hair, but it doesn't and 100 of them, because this is a nightmare. And I said, when I have cases like this, I get my PhD on one case when I start dealing with the different aspects and different approaches on a single case that give you hard time. But the end result was very rewarding. But you have to handle several procedures to come to this one. I happened to operate recently on a case. I think 1/3 of this calcifications. The case you showed is monstrous calcification. That patient who has a cystic component and a midline calcified craniopharyngioma and a 50 years old was operated in France, transsphenoidally, and they decompressed as much. They left some of the calcification. They felt it's attached around the stalk. And that was 2015 in Paris. And then 2 years later, he got his recurrence. They went again, decompressed and complemented with radio surgery or stereotactic radiotherapy. The problem, as you know, not all of them respond nicely to radiation therapy. And he came back just 2019, around July, during the corona. He is a local, and he presented to us. He wanted to go back to Paris. He could not travel. So he landed by the King Faisal Hospital, at my hospital. They refer him to me. And I said, I'm not going to go third time from below with this heavily calcified lesion. And he presented with a severe visual loss. So I went combined the terional, lamina terminalis, and prechiasmatic and opticocarotid. There were several avenues I can handle this calcification. Surprisingly, when I come to the calcification from the opticocarotid component, that calcification was heavily attached to the posterior cerebral artery and to the superior cerebral artery at the junction with the basilar artery. And I imagine any pulling from below, traction on this, if somebody who doesn't have the experience like you to make microsurgical dissection from below, it would be a catastrophic event with the major bleeding, and he could not control it. Because even from above, it was very tedious to dissect this one. And that calcification around the stalk was just behind the stalk. So we could save the stalk and take the calcification from underneath. Actually, I have put the case in my chapter for Professor, the endoscopic book that we are all involved in. But this is where I feel heavily calcified, you should consider twice, if you are not experienced with endoscopy, to go in the standard approach that is give you a better result.
Yeah, I was also thinking, Imad, come from lamina terminalis, but would I not get the part which is retroclival? That I thought maybe from enonasal, and the gland was already without function. So in this case, the pituitary sacrifice was a big deal, you know? Yeah. But we are lucky so far. When we leave a remnant behind and we get this stereotactic radiation therapy was done here in Greifswald, I have never seen a recurrence after this radiation. The opposite is true. Sometimes you have larger tumors and they shrink down. It's interesting. Maybe the follow-up time is too short, and in the next 10 years or so, we see more of recurrences. But so far, I'm quite happy, especially if we want to preserve the stalk and I see the stalk is infiltrated and the patient has a good endocrine function before I don't sacrifice the stalk. What was formerly our policy. I just leave a small piece attached to the stalk and send for radiation. Yeah.
Actually, this is the statement of Professor Yazargil, legend Yazargil, with craniopharyngioma. He used to say, I removed them completely. But after the years, when he got more gray hair, like now we all get, he said, wait and see. After 30 years, you might get your recurrence. Craniopharyngioma recur, whatever you do. This is his, of course, expression. Good outcome at the end.
Ramesh wants to say something about that as well.
Yeah,
Ramesh?
Thanks, Henry. That was a great case and quite difficult one. But I totally agree your approach. I think it's a transnasal endoscopic approach, and you managed to take most of it out. To me, at least a subset of craniopharyngiomas, this is the best approach, where you can get a radical resection. In these sort of cases where there is attachment to the floor of the third or side of the third ventricular wall, it's difficult. But in terms of perfused, non-perfused flap, that's a big issue. I've had a similar case where the patient leaked, had multiple revisions because it never healed. That's one thing, and I stopped using the Foley's balloon catheter to tamponade or to support the flap repair since then, because I thought the balloon was pushing onto the pedicle of the nasoceptor flap, making it avascular. So since then, I've stopped using it. And the second thing is I had a similar young chap who had at least 5-6 operations for a craniopharyngioma. Came with after an initial operation with cyst decompression through the nose, and then I went back in 3 times. Each time removed mural nodules in the cyst wall, but there was attachment to the stalk and to the optic chiasm which could not be removed. So after 3rd time, he came back for the recurrence after radiotherapy. During radiotherapy, he was sent as an emergency case because cyst was getting bigger. So went in through a supraorbital approach, managed to decompress the cyst again, but came back with further recurrence through the nose. Again, I was very hesitant to go back into the nose given the previous leak, but had to go back and decompress the cyst. But again, I'm sure that he is someone who's going to come back in future. So we're trying for new alternative therapies for such a case. So agree, I think these are difficult cases.
One more comment I want to say. I don't disagree with the approach in general for craniopharyngioma, because the line of vision is the best, is in the same axis with the direction of the growth of these craniopharyngioma. And when it comes to heavily calcified in the midline, this is where I become hesitant and their attachment to the vessels, unless it's done by a good microsurgeon that he's doing endoscopy.
Thomas, what is your comment, please?
Yeah, this talk or the subsequent discussion did very little to make me hate craniopharyngioma less. We all agree that there are, varied type of tumors, and really we need to use all our experience and wisdom. Then sometimes combined wisdom is very important. And as much as our kind of general approach is, pretty much always try transsphenoidally first. I also agree very much with Imad that, particularly for those who are starting, should ideally select more, feasible cases before they get familiar with it. And calcification is one of those things, although sometimes you can actually have heavily calcified lesion, yet fairly soft and amenable tumor. So yeah, one has to remain sensible and use all sorts of treatment options, including very much radiotherapy. And because some tumors actually do respond very well, some are very stubborn, even after radiotherapy.
Vladimir.
Yeah, Henry, congratulations. Especially that I see that someone else is having troubles as well, And as Tom, I hate craniopharyngiomas, and you see my hair. Should the endoscopy be here 20 years earlier, they would still be black. That I can grant you. I believe that endonasal techniques really changed craniopharyngioma surgery tremendously. There still are cases which probably should be approached from above, as Imad is pointing out. But really, endoscopy is a means for measuring most of the craniopharyngiomas. It's the best way.
Yeah, thank you. I agree. It was a struggling, but finally I think we could preserve the hypothalamus in a good way, although it was very sticky and with a sharp dissection. But the message is you never should pull, because what Imad said, sometimes very sticky to the posterior cerebral arteries. But here I could see everything with a good vision, and that was a big advantage. And then piece by piece, really 12 hours struggling. This.
Yeah, that's why why Thomas and me hate craniopharyngiomas probably. Thomas is
and we still do that. That's the trouble. I want to just ask the panelists, do you and when do you not use a lumbar drain pretty much even before you start, either with craniopharyngioma extended tumor or do you have any sort of thoughts about that?
In cranius, I usually place lumbar drain before we start with the surgery. When we have tuberculum meningomas or others where I do not open the third ventricle, and then I think it's pretty nice without any lumbar drain. The problems with the lumbar drain, if the patient is not compliant and he stands up and the drain is down, this can be really a disaster. So we have to be very careful, but I think we can reduce the pressure, and this helps with the healing, in my opinion. So if I have the danger of open the third ventricle during the surgery, I place the drain before, and then I leave it for 5 days usually.
Yeah. We started completely, pretty much never using lumbar drain, and increasingly easing through various tumors. The worst group of lesions around the sella are, in my experience, arachnoid cysts, intracellular arachnoid cysts. They have the greatest probability of leaking in our series.
Yeah, Tom, I think for arachnoid cyst, I stopped going through endoscopically at all. I do a supraorbital approach for those cases.
Okay, so if we don't